Hey, Jenner.
I made it, Erica.
Good. Do you want me to pull up the slides or do you want to pull up the slides?
If you have them handy, that would be fantastic. I don't know why there's a waiting room on this right now, so
Oh, weird. Nope, I got it.
it's going to keep admitting people. And Rachel is here.
Can you make it that oh, here we go. Can you make me a host or enable screen sharing? Thank you.
Hi, Rachel.
Jenner, can you see the right slide set?
Yes, I can.
Okay, it's in the right version or view.
Yep. Looks perfect.
Oh, I can admit people too, now that you made me, so I'll help admit.
Actually, I think I can turn the waiting room off, so now we won't have that problem. Hi, Dr. Koo.
Okay, I think we'll get started in just a minute. We'll let a couple more people join and then we'll get going. Okay, I think we'll jump into things. So thank you to those that have already started, but if you have not yet, please use the chat box to type in your name, position, credentials, email, and facility affiliation. This helps us keep track for grant purposes, as we do have to report how many participants and what types of credentials individuals have, so we can continue to get grant funding to do this type of education. If you are not from Montana, we just ask that you add in what state you are from, just so we can see if we have individuals from other states joining us. And then if you do have multiple people joining, we just ask that you please include all individuals that are on the call with you today. And then, as always, if you'd like to, please turn on your webcam. We would love to see your guys' face. So if possible, please do turn on your webcams if you're comfortable with that. And I think you all know who I am by this time, but I'm Erica Baldry. So I am the Infection Prevention and Control and Healthcare Associated Infections Section Supervisor here at the Department of Public Health and Human Services. And then we also have Jenna Minto, who is with the University of Montana Skaggs School of Pharmacy. We have Vince Colucci, who is with the University of Montana Skaggs School of Pharmacy. And then we have Dr. Neil Koo, who is with Billings Clinic Infectious Disease. So that is kind of the core group. And then today we have our speaker from last time returning to kind of give us an update on everything. So I'm really excited to hear what discussion we have today. So just going to move on to our agenda. So as I said, we're going to have Rachel presenting once again, kind of update on our case that we talked about last week. And then if we have time, we'll have Dr. Q give a quick presentation on preparing, a quick presentation on antimicrobial stewardship content, and then discussion. But with how last time went, we are prepared to spend a lot of time on discussion if we would like. So of course, this is your guys' time, and we want to make sure that you're getting out of it what you're here for. So just let us know kind of what direction we want to go in today. All right, Rachel, are you ready? And are you going to be sharing slides, or would you like me to run the slides for you?
I have no preference. What's easiest for you?
Totally fine either way.
I think maybe I'll do it.
Okay, perfect.
So I guess I just got a window when I tried to share my screen that this will stop other screen sharing. So
Yep,
do I
that's
just
fine.
Okay,
Yeah.
start over. That looks like me. So this is me, I think.
That is you.
Yeah.
Okay. Hi, it's nice to be back. I am this case. It just is turning out not necessarily how I expected. So I am fascinated to hear some conversation about it, especially from any of and it looks like a lot of the folks on here are really infection related. And I'm fascinated to get feedback on this case because it didn't go how I expected it to go. Round two. So I don't know if there are people on here that were not on here before. So I left in some of the detail from earlier, but I want to just sort of skip over. In short, this is a kid, again, I put in some new objectives. So reviewing some pertinent things so everybody's up to speed on where we left off, and or if people were not on the first time, they kind of are up to speed of where we are coming into. But I really want to talk about the antibiotic piece of this with appropriate use. We talked a little bit last time about recognizing clinical deterioration or clinical changes, but I think this has so many little snapshots of antibiotic use that I am so excited for people's feedback. And then I think also just sharing feedback guidelines and practice pearls. And I think in a case that is this atypical and complicated, it's nice to hear from providers, like what are the applicable pearls from a case that you might see once or twice in careers. This is the second for me, but this is more complicated than the first. So I really am excited to get people's feedback. So for brief, this is a 16-year-old kid who had several weeks of symptoms, was seen in the virtual clinic. Most everything was initially ruled out. He was put on a Z-Pack, went home, came back on Christmas Day, sick. Lactic acidosis, septic, respiratory pathogen panel was positive only for rhinovirus. The chest x-ray was negative, otherwise the workup largely stopped at that point. He was admitted to the hospital of service, which is my group. Started on essentially an antibiotic coverage, a gram of Rocephin, a dose of azithromycin, put upstairs. So the reality is initially the sepsis piece of him was recognized, but not necessarily worked up or chased, and as we talked about, in an appropriate manner. So put upstairs on the floor. First day did a little bit better. Antibiotics were discontinued in the setting of improvement, and a pathogen panel that was negative or positive only for rhinovirus. After that piece, once the antibiotics were stopped, later into that day and that night, he started to acutely decompensate again. So coming on, we had one blood culture pop positive for a gram-negative anaerobe that was not identified at the time. So fluids were initiated for hypotension. Antibiotic coverage was then added back on and a little bit broader with cefepime. And I think one of the things that Dr. Koo said last time, which is a really good pearl for one of our new-ish night providers, is when you have a sick kid in front of you who is getting sicker, and the only thing you have is that clinical picture with one positive blood culture, which we didn't necessarily expect it to be a gram-negative anaerobe. And I think it was initially thought of, well, that's maybe a contaminant, but as Dr. Koo pointed out, it's the only thing we had in a kid who was getting sicker. So brought into cefepime, and it turns out cefepime didn't cover that specific gram-negative anaerobe very well, but that was what we did. I came on that morning. Physical exam was consistent with a change. We ran him through the scanner. He ended up having meningitis and a left frontal abscess, and we ended up needing to find a place for him to go to get continued care. So as soon as we got the CT scan results, we did call infectious disease. Our typical referral pattern is St. Pat's, so talk to the infectious disease doc there. And his recommendation was vancomycin and Unison to cover that gram-negative anaerobe in somebody who was getting sicker. We talked a little bit about the logistics of finding a bed and a pediatric intensivist and infectious disease and neurosurgery in a 16-year-old. 16 is our sort of boundary or our delineation between our family practice folks covering patients and our hospital service covering patients. That being said, our group as a whole are internal medicine providers and don't do a lot of 16, 17, 18. We do 78 to 99 plus. So we ended up, I found a place at St. Vincent's and Billings. The recommendations from the accepting provider were a big fluid bolus, and if that fluid bolus, which was 2 liters, wide open in a 16-year-old, didn't keep his MAPS above 65, they wanted us to start him on pressors. He ended up not needing pressors on the way in the helicopter to Billings. He got to Billings, and as our radiologist recommended, they did do a stat MRI to confirm the findings from the CT scan. We had pushed all the images. So they did the MRI. Oops, that is not spelled right, but MRI confirmation, not conforming to anything. He did go to the OR, but interestingly, so the neurosurgeon is who initially wanted him in the OR, but the ENT provider essentially roto-rooted all of his sinuses while he was in there. So he ended up having essentially a complete left-sided opacification and filling of all of his sinuses, which was the thought of where that initial infection came from. So the ENT did the roto-rooter of the sinuses. The neurosurgeon ended up doing a burr hole, cleaned out all the subgaleal abscesses, some empyema, and that what was near maxillary abscess, intracranial abscess. So we ended up getting blood culture results from that one blood culture, which was Fusiform, Fusobacterium necrophorum, which is consistent with what was taken out of that abscess intraoperatively in Billings. Finding all those records and putting them together was actually harder than I expected. So the OR cultures were positive for Fusobacterium. The blood culture report from us, we ended up getting the one finding I never saw. And Jenner, did you ever see ID and Sensi for our blood culture?
I never did.
I didn't either, which was, again, I think the sending people out, it's so darn nice when we are all on the same, like can actually share information pretty well, but not very well. And interestingly, one of the notes from Billings said that there were 2 out of 2 blood culture positive for the gram-negative anaerobe, but we only ever had 1. And I never did see ID and Sensi. So a little bit of confusion as far as what was reporting. The interesting thing is the morning that we put him on a helicopter, we repeated blood cultures that ended up being negative. So he never grew anything else in his blood, which was interesting. So identified the bacteria and the sensitivity pattern in Billings, was sent back to our community to continue on 2 grams of Rocephin twice a day, oral flagyl 3 times daily for what was going to be a 6-week course. So that's how he came back to us. He wasn't back in school yet. He was mostly doing things online just because of how he was feeling, taking a while to get his appetite and his nutrition back, and just the back and forth to the hospital for twice daily antibiotic therapy. So continued on IV and PO antibiotics. He clinically improved quite significantly. He didn't have any new neurological symptoms, no headache, no anything. So he had followed up at the walk-in with who has now kind of become his default primary care provider, who's done a lot of legwork putting pieces together. They wanted a repeat or an interval CT scan, which was done on the 19th of this month. And I don't have the image, but unexpectedly, he actually had a larger area of abscess than originally was seen on the CT and the MRI. So he actually had a 4.8 centimeter abscess in that same place where he had had the abscess initially. That day, he returned to Billings with his family and went straight back to the OR with the neurosurgeon this time, who did repeat a burr hole, who put a drain in. They cultured it, and interestingly, it's an aseptic abscess. So they ended up keeping the drain in, sending him back to this community. kept him on the same antibiotics for the only culture data they had, which was the Fusobacterium necrophorum, and now has extended that period of antibiotic therapy until I think the 3rd of March is what I saw with the infectious disease note. So they interval CT scanned him again with the drain in, and he had resolution of some of the size of the abscess as well as the midline shift. So originally when we saw the CT scan from here, he did have some very subtle shifting of the midline with no neurological changes. This time he had a bigger area of abscess with more edema, more midline shift. And again, he didn't even have a headache this time or any symptoms. So that CT finding, I think for all of us was pretty unexpected. The placing of the drain did help with the collection of fluid, but he still had a significant amount of edema surrounding the area. And the drain is now out. He's back to school about half days, just based on energy and kind of a slow introduction, continuing to get twice daily, 2 grams Rocephin, and remains on the oral flagyl until March 3rd. He does have we're waiting for him to have a follow-up appointment with the neurosurgeon, but he is being seen here and followed by who's now his default PCP provider. So he's back in our community after twice going in with a burr hole and having maxillary or the intra-cerebral abscess drained. The first time junky bacterial with the Fusobacterium, the second time aseptic with a lot of surrounding edema, but he is now continuing antibiotics through March 3rd. So that is the update. So from my perspective, I think the antibiotic use and recommendations, there were so many pieces of antibiotic therapy. In retrospect, now knowing what the bacteria is that was identified, that initial dose of Rocephin in the emergency department that the bacteria was or should be sensitive to is probably the reason that white count CRP came down, had some clinical improvement initially, but then the antibiotics were stopped, got brought into cefepime, and then Vanc, and then Unison, and then Rocephin, and then Flagyl. So I guess my questions for you guys are thoughts about all of those complicated pieces of antibiotics, extending the duration of the antibiotics given the aseptic finding of the abscess the second time. And then if anyone has pearls of how do you take something that none of us may ever see again, I probably won't see again at this small hospital, to be honest. How do you take pearls from a very complicated case and apply them to use them? You know, we have had students, we have some new providers to take those rare cases, but to still have a framework in which to use or find usable clinical pearls. And then from our perspective, it's forced a lot of conversation in our group practice about how uncomfortable in reality most of us are with the concept of a truly sick 16-year-old. And we have had another one in the interim. I don't know that I've had a truly sick 16-year-old since I've been in Dillon, but we now have had 2 in a couple-week period. And I think for those of us who are not as comfortable with non-adult medicine or non-internal medicine, it's forced some conversation in our group where at this point now, when we have a truly sick 16-year-old, we typically do a 2-provider consult, and it's almost always somebody within our group or family practice, depending on the sort of size and status of that individual. So that's changed in practice. I think the other piece for us is who to call and when you recognize a significant change. But I would love to hear feedback from the group on the case start to finish. I am so excited to hear what Dr. Koo has to say about this entire transaction, because it's been awesome and so interesting, I think, for us. And then anybody else who's got pearls to share from a case like this. And as we talked about last time, being a small town hospitalist or small town hospital is like being a small town cop. You see less of the badness, but you still see the badness. And when you see it here, it makes it a little bit logistically more difficult to deal with and how to recognize and get people out and what your referral patterns are. Because again, for us, it's changed a lot about our intra-group practice. So trying to be short and sweet, just because that was the updates of the case, and I don't want to beat a dead horse of what we talked about last month, but I would like more discussion today, largely about the antibiotics, referral patterns, pearls, and how do we change our practice based on cases like this.
Thank you, Rachel. And I know last time I gave everybody homework to go back to, your group and talk about these referral plans and that kind of thing, because I think that was definitely something that sparked a lot of discussion last time. So Dr. Koo, are you available for some feedback?
trying to unmute myself here. Absolutely. So this is a fascinating case, and I, as I kind of mentioned last time, this would be something that that you typically will hear from at a university academic, large academic center, referral center, where there's like an ID fellowship program, and this would be a perfect fellow case presentation. And now, with that being said, this is not something, and I'm not sure this is truly a Lemire syndrome, but this is certainly, you're right, this is not a very common presentation, and this is not something that you have to look for every patient that comes through the door, especially a 16-year-old. All right, now, but you will run into cases where they're going to be similar to this, where you don't have the answer readily available, and then you have to determine what to do. One thing I want to ask you, Rachel, is did anyone do a spinal an LP on this kid?
No.
Okay, that's a little weird, especially with that MR finding. I'm sorry, the CT finding of meningitis. Although the sensitivity of CTs detecting meningitis is not that great. So, and I'm not sure what this, you mentioned in meningitis, but what the radiologist has actually put in their report that will lead to that conclusion, probably some parameningeal enhancement or something to that effect. And the reason I say this is because, again, what you're going to do is really depends on what the workup you have done. If you don't know what's going on with the patient, it's hard to determine, obviously. I mean, and that's where the emphasis, and I want to emphasize this, even in a little town, and now that many little critical access hospitals have a lot more than what they used to. Workup, you're able to do some of the workups to kind of help guide your what to do next, and as well as your therapy. So kind of going to your discussion point is what should you start when someone presents like this in the ED? I mean, and the inclination, and everybody, and I'm not going to fault anybody for this because everybody does this, is Vosin is like the big common thing. That's vancomycin and piptazole, or vancomycin, or whether that's cefepime or vancomycin, with meropenem, because that's like our for most clinician, that is like the safe choice, because you pretty much cover everything. And probably for the majority of the time, you're not going to go wrong, because for the vast majority of the diagnoses, you're probably going to cover a lot of these, a lot of the more commonly encountered organism and diagnoses with these antibiotic regimens. Now, with that being said, again, it's not we're here at discussing about antibiotic stewardship. So the issue is not the what can we do and what's to endorse so much of a gunshot approach, but more of a focus approach, so that we could identify, especially in cases like these rare cases where you're going to run into that. Yes, the antibiotic regimen for the most part will probably not going to cover cover the what's going on with this kid. So, so again, emphasis, diagnosis, do what you can, and whether this kid has meningitis, and that's why I was asking, if there's a meningitis, you wouldn't, then your antibiotic regimen would be slightly different, right? So that's kind of my point is the more information the better, the more helpful it is to determine what's the appropriate empiric antibiotic regimen, and subsequently the directed therapy. It also helps when you call the docs, because obviously you reached out to the ID doc, and their question is, what did you do? And what have you found? And if you don't have that information, the best they can do is to guess based on what the amount of information you provide. So again, going back to this, is the more you can do, the more helpful those consultants can be. I'm sorry, go ahead.
No, and your question, Dr. Koo, is so good. When I called the ID individual, one of my questions was, do I need to LP this kid? And his answer, which is so appropriate, is it doesn't matter what you do at that moment, you cannot keep him in your facility. Right. So in our piece, it was put him on antibiotics and get him out of the facility, because that would have, the LP would have delayed it would probably have been, thinking about the ED provider. Not all of our ED providers do their own LPs. The hospitalists, we typically, most of us don't have those kind of privileges anymore just because the hospital service is too busy. So thinking about, calling in anesthesia and that type of delay, I think he was spot on in saying, I would not do it there. I would get him to a facility. But I think in general, yeah, that popped up on my head as soon as I looked at the CT scan. I was like, do I need to LP this kid?
Yeah, and again, do what you can as much as you can. And you're right. Now, to me, LP, I trained back in the days when actually that the clinicians do the LPs, and we don't usually send them to radiology. Now that's kind of for a lot of places, at least larger institutions, that's a very common thing to do, is to send them to either ask a specialist like a neurologist or ask interventional radiology if you have that to do that. So, but anyway, those are kind of that's kind of my initial thought, and I know that it is challenging because again, every place don't have all the the capability, the manpower, or the skills are needed to do a lot of the workup. So, but these are kind of again, the more you can do that within your ability, the more that we can at least consultants, or at least to kind of help you direct where to go in the management of this particular patient. But clearly, it is that this kid did need to, it was necessary for this child to get transferred elsewhere. So that should be the kind of one of the big focus on that. Which comes down to is what are the challenges of getting patient transfers, and especially in time of COVID-19, because this is a time where, like, for example, Billings Clinic, we're really, we have, our hospitals are very full here and as well as St. Vincent's. And what are some of the barriers that you're kind of encountering? Because in the end, we can do all these things that we talk about, and we know that we need to get a transfer. But what can things be done to kind of what barriers do we need to address that will kind of help address your concerns about you have patients that need to be transferred, make that process a lot smoother.
And I think explaining to families, even because all of our referral centers, like literally you dial St. Pat's, and as soon as they know who you are, they're like, look, we don't have any beds. So if you need a consultation, I can help you talk with a consultant. But I think it's forcing rural hospitals to keep patients that have no business staying in a rural hospital, because there's just no, there were days, especially when we had a lot of Delta patients and staff was out and hospital, like all of our rooms were maxed. I mean, we're calling hospitals that are 11, 12, 13 hours away. There'll be days where we'd call 13 places to try to get a patient out, and you just can't. And I think that's forcing a lot of patients to stay in places where we don't have the resources to take care of them.
And that goes back to your kind of point, is that we need that even though you got the recommendations, you need to move this patient, but it's going to be, at least it looks like it's going to be hours before that's even going to happen, because I got to find someone to accept this. So then treatment is important, because that's a matter of time now. Now you're on the clock with if you're delaying treatment, antibiotic therapy right there, that again, that's kind of part of my point here is that, yes, your diagnosis, you're probably going to have to put in that position where you may need, that if you can't get this kid transferred, you need to kind of, try what you can to identify what's going on and address that the best you can. Otherwise, if you're just sitting there guessing, obviously it'll deteriorate and you'll end up with a really bad outcome. And that's really kind of one of the aspects of antibiotic stewardship, isn't so much to tell you what not to use, but it's important to kind of part of what you should use in this particular situation you're in, whether it's in the ED, what are the appropriate antibiotic therapy? Is vancomycin piptazole the best antibiotic for everything? No, I mean, obviously not. If they have a patient with meningitis, if you didn't get that diagnosis, piptazole is not going to treat it. So, and that's kind of my point is that, and so even if you can get the patient transferred, you still got to know so that you got them on the appropriate regimen, so that you're, as we kind of call it on our end, a train wreck. And that's what happens. So I hate to make it sound, but that's kind of like, is that we know that you're under stress because you have limited resources, but but that's kind of cross my, you hear that from hospitalists, with the receiving hospitalists is like, oh gosh, I got this train wreck from same elsewhere. So. And that's something we probably could talk about in future discussions about, looking, what are the appropriate empiric regimen based on some of the limited, some of the workup you've done. And that's actually, and that's a very common thing from many hospitals who employ kind of more with antibiotic stewardship, where we do order sets. I'm sure all of you have heard about that, where they look at not based on diagnoses, but actually syndromes. So what are the work and it's not just going to be focused specifically on what the antibiotics is, but also that if you that you can look at a general syndrome, fever, respiratory symptoms, that you incorporate the appropriate diagnostic workups. So this kind of falls into also diagnostic stewardship, where how you're going to what type of samples need to be collected, should be collected, and where they should be sent, what tests you should do, whether you should do sputum culture or versus biofire, or PCR based test versus antigen based test, so that will kind of help narrow your the direction at where you're going to take this patient in regards to treatment and further management. So
I'm curious to hear from some, the homework that was given by Erica of like, hey, what do you do and what's your call pattern? I'm curious, did anybody find any stumbling blocks, or was it more complicated than you expected, or was that information readily available? Like, I'd love to hear from someone else rural that's like, oh yeah, I figured out that we don't have a normal place that we call, or whatever some of those stumbling blocks are. Because again, I think we talked about this last week, for me to place a 16-year-old was so much different than placing a 50-year-old or a 70-year-old. So I guess I'm curious if anybody, I don't know, was enlightened by the process of trying to figure out what they would do to get a kid like this out.
Not sure if Tyler Hope, I know you're from a smaller hospital, or even Rindy, if either of you guys are available to talk on this, or Suzanne Radke, I know you'd be a good one since you're kind of in rural Eastern Montana. Any of those individuals available?
So Erica, I'm just going to jump in quickly while other people are getting brave. JC Ott from Billings Clinic typed in the chat, with Fusobacterium, they don't routinely do susceptibility testing, at least at Billings Clinic. So micro only reports the organism ID, and then they go off what's reported in literature.
Okay. And then I'm guessing based on the recommendations that ceftriaxone is sort of the go-to for these bacteria?
Not anaerobes. So kind of step back here, just follow up with what JC said. Most institutions don't do susceptibility testing on anaerobes in general.
Thank you. Okay.
All right. So if that's what you're waiting on, you're unlikely going to get it as part of the routine. Now, personally, I don't think, from my experience, I've never specifically asked for antibody susceptibility and anaerobes in general, because depending on the situation, but just because they're usually antibiotic resistance isn't as big of an issue in that for those pathogens as those more anaerobic. Now, with that being said, doesn't mean that there aren't resistant anaerobes. Clindamycin, for example, many of oh gosh, I'm just drawing a blank. The Bacteroides are not susceptible to clindamycin, so it's not going to be a very good option to use clindamycin. Conversely, metronidazole is not very good, and a lot of the oral anaerobes as well, even though you hear about that. So there's that kind of that flip, and so there are some caveats to that. So fortunately, it's not as big of an issue with when you're using Unison or Piptazo, because I mean, most of them are pretty susceptible for both sides, up in the oral area or in the gut. So we usually don't think about it. If you put someone on Pitazo or Unison, it covers both the oral and the gut. But just to kind of let you know that Clinda isn't, and Flagyl or metronidazole have limited. So you may want, those are the kind of the exceptions more that they don't compass all anaerobes.
Okay. And I guess maybe Dr. Koo, since you are on, the recommendations, the 2 grams twice daily of Rocephin with the Flagyl, is that intracranial or intracerebral abscess dosing, or is that continuing to be meningitis dosing, or both?
It's probably both. We actually had another Fusobacterium case, but that I got asked to see, but this is the different one. So I thought that originally I thought your case was that lady, but turns out since you said it's a male, then it's a totally other case. So yes, and if it involves a meninges or in that area, we usually push for the higher doses.
Okay. And then would you do the same thing with the reaccumulation of the abscess, even though it's aseptic? Would you, because I think the recommendation then was to extend the antibiotics like another almost 2 to 4 weeks.
Now that is a clinician decision. Okay. and so this is where it gets really gray because the duration of antibiotic, although we know a lot of durations, and this is again another antibiotic stewardship topic we'll talk about in a future session, where there are a lot of conditions where we have set durations, such as pneumonias, right? UTIs. We have very set, usually you don't need to treat, this is about the duration, 5 to 7 days, something like to that effect. Things with that who are a little bit more complicated, and this is where it falls into where this is a little considered to be complicated infections that involve abscesses or areas that we don't commonly treat. We usually depend on the experience and comfort level of the ID specialist may choose to do a little bit longer duration. And this is uncommon. This is fairly common, like in spinal disease, someone with osteomyelitis discitis, we treat 6 weeks, but if there is a complication, we'll treat like even longer than that, triple the duration. Is there any science behind that? No, and true of the matter is majority of the time, the decision to do that is out of more of a concern. Will it come back? And I don't want this to come back kind of more, rather than there's actually a evidence and data to support that practice.
I was just while I was getting ready to log in, I was discharging somebody who is immunosuppressed on a course of Augmentin, and I found myself doing that same thing. It's like, well, normally I would do this long, but they're immunosuppressed and they live out in the Big Hole Valley, and it's like, you sort of choose to I'm going to make it a little bit longer than I normally would, but I don't know that there's great data.
But obviously, you have to balance that, the decision to put on prolonged antibiotic therapy with that of with the possibility of complications, C. difficile infection, which is the most, the biggest one that we know about. So it's not without, and yes, in the past, it was very easy for us or for all clinicians to say, hey, longer is better, because one, at least, I'm covering myself. And that's unfortunate. That's kind of what a lot of even ID physicians do, is I'm kind of covering myself. If I do a little longer, it's okay. But now, we're seeing a lot of more complications related to antibiotics, and we're picking up, like quinolones, for example. In the beginning, I'm guilty of it. I've placed patients on quinolones for 8 to 12 weeks before, until kind of started seeing all these complications with QT interval prolongations, tendinopathies and things like that. And then now I'm like, have to rethink, well, is that, what I'm treating worth that risk? And that ultimately comes down to, but for the majority of the diagnoses, no, you don't need prolonged, even though there is that fear, and that's the hardest part. And this is one of the biggest challenge for antibiotic stewardship, is to overcome the clinician's fear that if he didn't do it, if that person didn't do it, that clinician didn't do it, that something bad will happen.
My other question, I guess this is like for anybody antibiotic related into the group. So I mean, we talk about penetration into an abscess or penetration into specific tissue, and then to have an abscess that's inside the blood-brain barrier. Like, I guess from an antibiotic perspective, are there many regimens that you could do to have coverage for something that is intracranial and is evidently, encapsulated in an abscess cavity?
So the general mantra is that if there is an abscess, you want to make every attempt to drain it. Source control. I mean, hence this big why when ID physicians get really irritated when surgeons, are reluctant to, or our interventional radiologists won't drain a little intra-abdominal abscesses because, it'll go, and I don't understand why they feel that way, but is that we know from experience that, is that if you don't attain source control, the likelihood of successfully treating that infection is not very high. Obviously, you want to get the patients the greatest chance of recovery. So draining an abscess is going to certainly improve that. Now, with antibiotic stewardship is that it also shortens the need for the duration of the antibiotic therapy. So the more you can drain, the better it is. So in general, now thirdly, and this is probably the big, and again, another antibiotic stewardship thing is to identify the organism causing the abscess. And that's also, because many times we can empirically guess, as a patient presents with an intra-abdominal abscess or brain abscess, we can kind of guess, okay, what it is. But if our goal is to narrow the antibiotic regimen and to get this, and certainly in addition to shorten the duration, you want to drain that abscess. So it's not just draining, but also identify the bug that's causing it, and to make sure you're on the right antibodies too, because there are other things that obviously can cause intrahepatic abscess. Now antibiotics don't work very well on amoebas. So so again, so there's a lot of other factors. Again, kind of going back to that whole notion of identifying, because and that's the challenge, is trying to fight, trying to encourage, to get the procedure done, because the more information you have, the better outcome your patient can have if you know what you're dealing with and how you're going to treat it.
The only thing I would add to that great answer there, Dr. Koo, if you're looking at specifically to the drug, I think sometimes we have to look at, does the drug penetrate that area, inflame meninges and so on and so forth. I mean, the best drug for that bug in the site, and can you get distribution to that site? So just to add another variable, another confounder sometimes, and it I think underscores the need for that team approach and to optimize all aspects of trying to treat that from a stewardship perspective.
Is there let's say that the individual really did have a cephalosporin allergy or something, what would be an alternative regimen for, again, assuming you have source control and it is drained, what would you recommend as another alternative regimen for the Rocephin flagell?
Now this is where then we offering other alternatives. So meropenem or carbapenems would be an option. Certainly you can consider that. Probably I would go with the meropenem rather than be the easiest. The ertapenem, although usually we don't use it for CNS or perimeningeal infections, at least I haven't, and imipenem, silastin, or primaxin is a little harder because it's 4 times a day. So you kind of also have to balance. When you send this kid home, how you're gonna incorporate their therapy at home. Now that's ID docs do that. We do that all the time. And also, we try to match the most appropriate therapy with the condition, and then try to also consider. But I do ask that, and this is something we get asked quite often, that people that can't you just give that Rocephin and once a day thing, or something that's once a day makes it. It's not that we choose the more the complicated, it's what will be appropriate for the patient. So that's so kind of keep that in mind. And I know you don't send patients for us in that context, but we get asked that question a lot. And it's like, it's not that we want to inconvenient to make it inconvenient for a patient. So So there, yeah, so meropenem is our meropenem, probably the most, the other more common cephalosporin is a viable alternative for this. But again, we don't do this first line because for other reasons, we're still we're trying to preserve the meropenem mainly because of trying to reserve that for more resistant organisms, and such as those with ESBL producing organisms and such.
It's interesting, thinking just like sort of backing way up when you're discharging somebody from the hospital for a more common version of an infection, and you think about their life logistics and, if you have a couple of options, what is the easiest dosing? Or if you have patients that are not going to be reliable to take an antibiotic 4 times a day, what's the alternative just based on their logistics, if you can simplify. I mean, in this case, I think there were not that many options. And the good news is with him being out of school, coming in twice a day, and I think now we're in the process of transitioning to home health, but we're a community where home health is pretty overwhelmed. So to go to a house twice a day is tricky, which is a lot of why he's come to outpatient therapy. But I think just, thinking about the convenience but not being able to get around, you got to have the right, as Vince said, the drug for the bug.
But any other questions about referral process or whatnot, and empiric therapy, for cases that's similar to this?
I know, Rachel, you said you've seen, 2 sick kind of teenage aged kids lately. Has anyone else seen kind of this abnormal or this, kind of select group of individuals lately as well? I mean, is this something other facilities are seeing and something we need to be kind of thinking about? You guys can use chat if you're shy.
I think, as I said last time, like we are our capture area is pretty big. We are so stinking lucky that we actually have a full-time hospitalist service. I think some of the rural providers that talked last week were ER providers that also act as hospitalists that sort of do the big picture. So I think those, for better or for worse, I think those folks are a little more used to seeing sick kids compared to like a legitimate internal medicine provider run hospital service. So we sit in a really lucky position to have a fully staffed hospital service. But, I think the flip side of that is that we don't have that kind of experience. We have family practice providers that typically would do the 16 and under, 15 and under for us. But oftentimes, even if it's something that's a 14-year-old or a 13-year-old complicated, they'll still consult the internal medicine, our hospitalist service. And we just don't have as much experience in that population.
Sandra, I saw you unmuted. Were you going to say something? Or Rindy? See, looks like
Hey,
you.
yeah,
Hi,
I'm having some technical difficulties with the camera. I was gonna say, we are that facility where we don't have ICU capabilities. We're 25 bed. Our ER provider can tend to be our hospitalist and different things like that. So the first round of grant a few years ago, one of the deliverables was having empiric therapy for those folks that are hitting the door with suspected UTIs and, down the list and I think, kind of answering that question about being super rural, 2 hours from one facility from Logan Health, and then an hour and a half from Great Falls, we are transferring people right away with any signs of sepsis. And I don't think we've ever had any problems with that. On the flip side, we're glad to offload patients that are more of swing bed or, need occupational therapy, physical therapy, maybe some, IV antibiotics for some post care. So that hasn't been a problem. I was going to say, I really wanted the ceftriaxone, so fascinating. And this case is so fascinating. I feel like in our facility are overusing ceftriaxone so badly in our ER. And that's been one of the things that I want to focus on with our stewardship. just kind of do maybe a little DUE on it and just show, you know, that people are coming in with, I don't know, just some random things, earaches and sinusitis. But there you go. We have seen a kid with sinusitis recently where we gave him ceftriaxone. So that I guess I shouldn't have said that after this case. I was going to say in our facility, I feel like we're doing pretty well. We do have one provider that kind of does what they want to do because they're old school and they've been doing the same thing for a long time. I've been told I'm not going to have a pharmacist, you know, some pharmacists tell me what to do, but I really try to discourage the use of vancomycin, meropenem, and piperacillin, unless we're looking at some kind of a bug that, you know, is appropriate, you know. And so I guess that's kind of what we're doing. And we're pretty small CAW. And I feel like a lot of the CAWs we're kind of all in this, a lot of us are in the same boat. And so Dylan, I think you guys would be definitely a step above us with your capabilities, but we transfer patients at any sign of things we can't handle just because we don't have the monitoring and capabilities. So that's all I wanted to add.
Thank you, Randy. Appreciate that.
Well, that's you know, thank you for that. That was a great point because I think it underscores what Neil was saying, what Dr. Koo was saying in terms of like, if you're worried about something, let me give a big, broader antibiotic that can cover more so that in case I haven't identified something or missed something, then I'm covered with that antibiotic and give them that shotgun approach. And that's, I think, an age-old type of a situation. And you know, how do you re-educate and try to narrow that spectrum down in terms of what the bullets you use in the shoot there, if you'll pardon that pun, but that's you know, that's I think that's a perfect example of do you need ceftriaxone for everybody that walks in the ER with, you know, with some sort of a potential infectious process.
And I don't know if again, in our ED providers say it really tongue in cheek, if they're talking to one of the people in our group about an admission, you know, I'll say, did you start them on antibiotics? And I'll say, or what did you start them on? And sometimes they'll say, I only know 2 antibiotics, Rocephin and Zosyn. It's like, okay.
Sounds like my urology friend. They only know Cipro. That's all. That is the only thing they know. But and really, my point here is not to really kind of shame all your providers or all ED providers or hospitalists in that you know, but more to kind of what as we start having further discussion about how do we going to refine different aspects of your antibiotic stewardship program, the behavior is going to be the biggest challenge because a lot of this behavior has been ingrained, you know, to you, the type of the specific antibiotics is ingrained. And part of that has been, that's been kind of evolved from either training, you know, so if you're trained at it, depending on where the physician has been trained or any provider's been trained, that's what they do. That there's a very good chance that they're going to continue doing that. The other is that again, many hospitalists, and when I was a hospitalist, I fell in that trap as well. Is that you kind of just like, you know, when things get busy, you just don't want to think about it. You just kind of throw it. So you just kind of throw, yeah. And I remember I used to work with a hospitalist who every patient that she admitted was on Pip-Tazo. It doesn't matter what the disease was. There's pneumonia, we'll put on Pip-Tazo because there's that notion that, hey, it's broad, I'm covered. And because she only does admissions, her assumption was that I'm just going to do this and then I'm just going to let the daytime doc take over. And what commonly happens is that the daytime doc thinks that, oh, the nighttime doc must know something that I don't know, so I'm going to continue that patient on Zosyn because that's must be the right thing to do. So you kind of see a lot of antibiotic stewardship is going to be it's going to surround behavior and behavior changes. So and some are going to be a lot more resistant, surgeons in specific more than hospitalists. certain groups will be more resistant to that push. But so again, we'll kind of talk a little bit more about that, but just kind of thinking this is kind of really good kind of primer for some of the things that we're gonna in the coming months that we'll touch on.
Thank you, Dr. Koo. Any other comments or questions? I know we have a lot of rural hospitals on here today. I know I can tell your guys' names and I know where you're from, so I don't want to have to call y'all out, but anybody else have any comments or anything like that that you'd like to add to today's discussion, or did this prompt something that you'd like us to do a presentation on? Okay. Couple of things I wanted to bring up today, just related to the Montana Antimicrobial Stewardship Program itself. So one thing is attendance at these Montana Antimicrobial Stewardship Coalition webinars are part of participation in the Montana AMS program. So please do continue to attend these. The antibiogram survey will be due March 1st, so please keep an eye out from a survey that'll come from me. Jenna and I will get that put together, get that sent out, and that will be due March 1st. I know we've gotten a lot of questions about how to put an antibiogram together, what an antibiogram is. And so if you do need assistance with it, please do let us know. If you would feel like it would be a helpful thing to do a webinar on, I'm going to add a question in on the antibiogram survey that asks, would you like a webinar on this? And we can definitely take a series or a webinar place and do a presentation on antibiograms if needed. And then the annual NHSN patient safety component survey is also due March 1st. So we've got quite a few things related to the Montana Antimicrobial Stewardship Program that will be due March 1st. So I just wanted to get that on everybody's radar. And then please do keep an eye out for any additional announcements from our program. Our next webinar actually works out great. It's going to be on March 2nd. So in a month from now, same time. But any final questions or comments or discussion that anybody would like to have? We've got 5 more minutes and we've got some great individuals on this call that I think have a lot they can add.
I would just like to throw out one more comment, Erica. For those of you that are on the call, if you have pharmacists, providers, if you are interested in presenting a patient case on this webinar series, please reach out to me or to Erica or Vince. We would love to have you present. It does not have to be a case that's as complicated as the patient that Rachel presented, because you're going to be probably hard pressed to find a case this complicated. But we would love to have some discussion over some of your more routine cases like urinary tract infections. I mean, is it difficult to find an appropriate treatment regimen in a particular patient case? What thought process goes into that? If you have a quality assurance project that you're working on, we'd love to have you present on how you have set that up, what progress you've made. It can be really anybody from your facility, but we would love to have a little bit more activity and interaction from the critical access hospitals in particular, because I feel like this has really been great having Rachel on here and bringing a kind of a different spin to it with, a hospital that does not necessarily have the same resources as our larger PPS hospitals. So please reach out. We'd love to hear you.
Hey, this is Rindy again. I do think that sending out some empiric therapy, and I know they're based, we base them on antibiograms and things, but I really do feel like antibiograms in our small cost setting aren't very, we don't have a patient base that's really, we don't have enough patients to pull data that really is relevant. So it'd be really cool to see some of the ER in larger facilities, their empiric therapy guidelines, so that we could kind of, adapt them to the cost setting, and maybe in the cause we could all have a little bit more continuity. I think that would help, but I don't know if Dr. Koo or if anyone would have some guidelines like that we could kind of share and look at together.
Absolutely. There are many things that we could do with that. We could set up a website, like a shared drive or site where people can look at their what would be recommended just in general. For those for those who are affiliated with Billings Clinic, and it's probably, and anyone can do this, we have a app that we commonly use. We offer our providers for Empiric as well as the diagnosis directed therapy. It's kind of like it's more of a Sanford guide that is a digital device, so we could certainly, I don't see why we can't, but we could certainly make that offer that for the community. There are, now, and certainly you can pay money to do the Sanford guide. They do that as well. But I think that, I think that, maybe, let me see if I can work on maybe setting up like some of the things that we do here at Billings Clinic and maybe a few other places, and so that you can kind of model after, or you can tweak it to fit your facility. So yeah, I'll work with Erica, Jenna, and Vince about that.
Okay, anything else today? Lacey says that this was a fantastic case study. Thank you, Rachel. So yes, big thank you, Rachel. We do appreciate you taking time. I mean, two of our webinars back to back to present for an hour and to talk about what you guys are working through. So we do really sincerely appreciate that. We need the participation of everyone on this call because you guys are the ones that are experiencing a lot of this. And I think that's the only way we're all going to learn. So we do really encourage you guys to step up and to present on these calls and to help us out.
Thank you for having me. It's been, I think sometimes, I don't know if other people feel like this in rural locations, it's easy to feel a little bit professionally isolated. So it's so nice to bring something to the group and have discussion and feedback. And it's nice to feel like you're not out there like an island. So thank you so much for having me.
Great job, Rachel.
Thank you, Rachel.
Thank
and
you.
For those of you who want to present, you don't have to have a complicated case. Even a bread and butter case is good. I can find something teaching points from it. So yes, feel free to throw any case that you want, and we'll work with it.
All right. Well, I hope you all have a good rest of your day, great rest of your week. And as always, if you guys need anything, just reach out. We're more than happy to help. We'll talk to you all next month.